All right, so our assessments, the dental hygiene process of care, observation. I don't know why I have what. What do we want to observe? Let's see, I wonder if see if I have notes. Hold on a second. What do we want to observe? Well, maybe that's what I mean. What do we want to observe? There's all kinds of things we want to observe. I'm just going to keep moving. So we want to observe their personal situation. How are they doing? Are you able to get a hold of them? Have they gone MIA? Did they used to come in every 6 months and all of a sudden they're not there anymore? How are they doing with their ability to remember and process the things that you tell them? Are you seeing changes in their behavior? That's potentially good things to observe. You want to check their medical history and their dental history for significant changes in medications and systemic conditions. EOIO, monthly oral self-evaluation. You want to encourage them to evaluate, especially while their cognition is still good, evaluate their own oral cavity for signs of cancer. Radiographs. We want to check their radiographs and see what's changing in the bone levels in their teeth. Oral hygiene status. Do they have the ability to perform? How's their dexterity? How's their vision? Nutritional status, transportation to get food, ability to cook, finances, ability to chew. How's their diet? How's everything happening for them? And are they maintaining or are they deteriorating in all of these areas? Modifications. So when we want to assess modifications, accessibility of the dental office. Can they get to us anymore? Are they having trouble getting into the building? How's the parking lot? How are all these things? Is this prohibiting them from coming to see us? Fatigue easily, stress reduction. Are they getting tired? Are they still full of energy? Do you need to change their appointments to be a little bit shorter and maybe more frequent? 2 hours is the absolute limit for really most people, but if you're dealing with a very fragile older individual, for sure, you want to keep it probably well under 2 hours. And then you want to include transportation time in that because the whole thing is going to be very exhausting for someone who is quite a bit older and who's dealing with chronic conditions. You want to always be assured that someone's there to assist them with walking and getting into the building. And dental chair position, the level of knees are higher if the patient cannot bend. Help them get into the chair without you physically like picking them up and moving them. You want to just be there as a support. Keep the dental chair high so they don't have to bend down as much to get into the chair. Make sure the armrest is out of the way, and that if they need a wheelchair transfer, that there's people to help in that, so that it's like a 2-person wheelchair transfer, or if you have that equipment, or if you have to see them in their wheelchair, that might be what has to happen. Modifications, reviewing the forms. So if there's hearing or vision impairment, think about what they can retain, what they can understand you've said. Can they read the material? Will they remember what you said? So think about assistance for the forms. Is the print large enough? Can all these things, have it ready for them so that they don't forget something important that you've told them. Low pitch when you're speaking to them. With a face mask, remove your face mask. Well, isn't that a hard thing to do these days? But this is really important for when you want to communicate with your patient. Shouting is unnecessary and ineffective, so keeping a lower, probably louder pitch, especially if you have to keep your mask on when you're talking to the patient, or in writing stuff down. Eliminate background noise. Music in the background can be very difficult for them to listen to you and hear the music in the background. Hearing aids, leave them in for the interview and then remove them once you start using your ultrasonic, or have them turn it off once you start the ultrasonic. If they're accompanied by a caregiver, speak directly to the patient, creating a respectful environment, but be sure that the caregiver hears everything and they know what the expectations are. And then legal considerations, informed consent, who signs it, who is the one that's legally responsible. It may still, going back here for just a second, it may still be the patient, or it may be the caregiver, so you have to determine that. Planning. So the planning is going to be more complex. There's chronic conditions. There's more complex periodontal and dental conditions. Again, we're dealing with their ability to tolerate the appointment. You want to evaluate their needs for pre-medication. There's going to be a lot more things that could come up. You may not have a policy that says they need pre-med, but maybe their surgeon who did the joint replacement does. So you need to determine that. Functional age versus chronological age. And you want to consider that while you're thinking and planning. Maybe they're young, but maybe their functional age is not young. Maybe they can't handle certain things. Human needs. What are their human needs? What's the most important thing to achieve? Comfort and health, but maybe, perfection of something is not necessarily a realistic goal, but maintaining comfort and health and their ability to eat, these things. So you need to adjust goals to what their human needs are. Perception of needed oral health care. They may not need or want a crown, but they do need and want to be free of pain, to lower their bacterial load, and things like that. So we need to make sure that we're thinking about and on the same page as their perception of their needs, and then what we can educate them still as to what's important. So they may say, I don't need cleanings anymore, I'm old. Old people don't need cleanings. You'll hear them say funny things like this. And so then we have to say, well, you do actually need cleaning still, and this is why, blah, blah, blah. Dental hygiene process of care implementation. So reduction in healing capabilities. They don't heal as well. As little trauma as possible. We don't want to cause undue trauma because everything is, not tip-top like it was when they were 20. Oral retraction is uncomfortable, really yanking and pulling on the tissue, so we want to be very gentle. There's a loss of elasticity in the lips and oral mucosa, and if they're dry, sometimes their lips crack if we pull too hard. So we just want to be very gentle and very aware of how we're handling their whole body. Specific oral hygiene instruction to ensure necessary knowledge and skill. So we adapt it to their needs, not what we think everyone should know and do, but to what they can handle and what will give us the biggest bang for the buck, I guess I should say. One piece of oral hygiene that they can handle, they can do, and that will help reduce their bacterial load. End of the appointment, the dental chair, you want to raise it slowly to an upright position. Never let them hop out of the chair. I don't know if any of them will, but don't let them do it. I have seen it. I've seen them wanting to get up, and then they have that lightheaded, that orthostatic hypotension. So make sure they're rising slowly. Allow them to sit upright for a short period of time before you dismiss them. Let that blood equalize in their body. Assess for the needs of assistance to walk them out. Offer them your elbow. Post-operative oral hygiene instruction, write it down and review it because they may forget, they might not have heard you, they might not be able to see it well. Think of all those things. Evaluation, frequent perio maintenance appointments. It's better to keep your appointments short and have them come in more often, or if they're still mobile and getting out of the house and coming in for appointments. Evaluate carefully. Evaluate their physiological, their chronic conditions, their pathologic findings. These things can change very quickly. You can have an elderly patient who's full of just, I was going to say, something in vinegar, just full of vivacious life. But then all of a sudden, within a year, something changes. They have a stroke and they've gone missing. You don't know what happens. Next time you see them, they're frail. This can happen very quickly. So we want to keep tabs on our older patients. And our patients that go missing, that we don't see, that we know are our older patients, reach out to family, reach out to them, find out what happened. Did they go to assisted living? Is anyone caring for their oral hygiene? This is an immensely important thing that we can do for our patients as they age. And it can also, you can also connect with hygienists that you know are doing direct access. If you've had a patient that you've cared for that you love and all of a sudden they're in assisted living, talk with the family and try to connect them with a direct access dental hygienist so that that patient doesn't lose connection with an oral health care provider. Health status can change quickly, cognitive changes, evaluate functional ability to complete their oral hygiene and their nutritional changes. Modification oral hygiene instructions, proper positioning. They may need pillows or bean bags or an airbag or a small or large chair, something to help prop them up. You want to remove any appliances in their mouth, physically supporting or aiding in their daily oral hygiene care. How can we modify things to help them? Visually inspecting the quality of oral care. We want to retract so that we can see things really well. Visually inspecting tissue for oral lesions, lesions from dentures or oral cancer or something, encouraging the patient during and after dental care. We want to talk to them, find out how they're doing, check in with them during the procedures, and just in general, provide written instructions for the caregivers. When we think of adaptive aids, we have to think of the size and their grip strength. This is just like with special needs. The size of the toothbrush handle, how's their dexterity, the shape of the toothbrush head. Can they rinse? Can they just swish and spit? How lubricated is their oral cavity? Do they need a supplemental saliva substitute? Sponges and swabs or gauze, to keep things wiped out. Can the caregiver wipe out after they eat to make sure food doesn't hang around? Can they use power flossers or power toothbrushes? Can we lubricate their lips to keep things from drying and cracking and causing secondary bacterial infections in the corners of their mouths or candidiasis? Management of xerostomia and caries, professional application of fluoride or SDF, silver diamine fluoride, 1.1% sodium fluoride or 0.4% stannous, take-home gel trays, xylitol products, constantly, every couple hours popping a xylitol mint. That helps with saliva production and caries. Mechanical removal with a power toothbrush. Choosing a power toothbrush over a manual is really preferred if they can tolerate it. Modification in toothbrush, handle size and width and grip. Prescription strength fluoride, the ACP, the amorphous calcium phosphate gels or pastes, antimicrobial agents, saliva substitutes. There's so many on the market. Start to get familiar with the products that are out there. Nutritional counseling for caregivers and for the patient, reducing the refined carbohydrates. And then aging population, selecting a dentist. So transportation, how do they get to the dentist? How close is the dentist to where they're living? They may need to find a new one. If their dentist, if they go to long-term care and all of a sudden their dentist is an hour away, they may need a closer dentist. How's the building? Can they get into the building? Does it have wheelchair ramps and whatnot? Training, education, and experience. How much does the dentist feel comfortable dealing with a frail, older individual? And then what are the treatment goals? The dentist may be like, oh, you need a crown on every tooth, but do they really? It's what are their goals and their needs to maintain health and meet their human needs. On-site dental programs are amazing and they're becoming more popular. The advantage over the traditional office is that the patient's right there. They don't need to go anywhere. That reduces stress. It's if they're incontinent or if they're catheterized, moving them about is a really big deal. If they're able to just stay in their bed or stay in their wheelchair, less disruptive to the facility, obviously, if somebody comes to them. Similar or familiar environment, it reduces stress. Providing care, there might be a permanent space that's dedicated to the dentist, or people might bring in portable equipment or bring in a mobile dental vehicle. So the barriers to care for the elderly can start to become tremendous depending on the state and how much the Practice Act allows for dental hygienists to come see them. But insufficient number of dental health providers in general, to dentists especially who want to go to these long-term care facilities and nursing homes. Poor attitudes of dental professionals. Low financial return. They don't make as much of a profit, and so they're not as interested. Inadequate financial coverage, not covered under Medicare. Federal benefits, Medicaid, state, vary by state. So Oregon does reimburse dental hygienists through Medicaid, but that's not in every state. Hopefully that's going to become more and more as time goes on. So the dental hygienist's role: provide clinical care, provide in-service education programs for staff and family members, refer if they detect unusual signs or verbal complaints, you want to notify the caregivers or the family members that this patient really does need to go see a dentist. They're in pain. There's something that's endangering their health. Brief oral health status examination, evaluation. So this is just something that every patient in every nursing home, every long-term care facility should go through, is just a frequent oral health status, especially when they first come into a facility. But is there anything major going on? Do they have dentures? Do they have partials? Do they have loose teeth? Do they have an abscess? Things like that. Marking dentures for identification. Can't tell you how many times dentures get misplaced and given to their roommate, instead of the owner, and so they have to be marked for identification. Providing fluoride application, saliva substitution, all these sort of things. Developing individual care plans for each patient. They may need someone to come in once a month. We're talking assisted living here, long-term care facility, nursing homes, but they may need somebody to come in and brush their teeth. A healthcare provider that knows how to effectively brush teeth every month, and this might need to be set up with the family members, because the caregivers don't always have the time and the ability or the desire to do this. Modifying oral hygiene aids for the caregivers, for family members who do come in and do oral care for their mom or dad or, brother or sister or whatever. Okay, we're going to stop it there, and then we'll pick up with palliative care.